Good morning to those where it's still morning. Good afternoon to those who have crossed the halfway point of the day. Really excited to have you join us. And I'm very excited to have this Bearing on Health webinar with my friend, Debbie Schapira, who really is an expert in many things related to healthcare and healthcare delivery, but in particular has a really distinct point of view and real depth of experience in blending in-person and digital care. And so we're excited for this conversation about what the future of the physical clinic should look like in a hybrid model. Debbie, maybe just start real brief introduction.
Good morning, good afternoon. Great to be here today. Thanks so much. I've been working in tech-enabled care delivery for over 20 years. It all started with a passion back from my youth connected to a soccer injury that made me an early consumer of healthcare. And growing up in Silicon Valley, we're seeing technology changing how we interact with all facets of our life and seeing firsthand companies that were experiencing integrating technology into the healthcare experience. And so that's where I've been doing my work. Really enjoy working, particularly in hybrid models, because I personally am a firm believer in you meeting patients where we are. And as we all know, oftentimes it needs to be in a physical space, but very often there are limitations and ways that it is not cost effective to do.
Let's start with the blank canvas question. If you were designing a new care provider from scratch, what would you do in the physical space?
So, starting from scratch, always taking a first principles approach of what problem are we solving for? Who is our patient? And what is their need? It goes without saying the needs of a pediatric population versus a Medicare population are going to be very different versus a commercial versus a direct pay population. So, first, I'm going to start by asking what are the needs that we are serving for this patient? Secondly, I'm going to ask, what are their prior expectations and experiences? Many, just because a technology is available doesn't mean a patient or their caregivers are ready to receive it. And these are things that I'm going to need to be informed on, as well as the competitive dynamic in the market and any insurance and regulatory regulations that have requirements surrounding the care. Once that is established, we're going to want to know what absolutely required being done in person, right? So is there a diagnostics requirement where a physical interaction has to take place? Is there a convenience requirement where there is a proximity where we know that we are going to be able to capture new patients, whether that is to attract new patients or proximity to other services that we need to be wrapping around? And then secondly, I'm going to layer on even when we are trying to build in a virtual world and virtual care, if we have a team that is in person in the physical clinic who is going to be providing some of it, how do we think about the utilization and time of that staff?
I really like that. It echoes what we heard in our survey of our readers that most would start with the patient experience. So I think you described how you'd understand the target population, what are their needs. You then think about regulatory, you think about billing, and then you think about time of the staff. Let's stick with that starting with the patient. It seems to make sense, but wouldn't you be concerned then that maybe you don't actually set this up to bill or you don't set it up for the workflow? Historically, the clinic has been designed as what is optimal for the clinicians and their workflow to be most efficient.
Sure. And I would argue and say it's an and, not an or, right? For any service provider, your biggest risk as an organization, one of your top risks is going to be what does it take to retain our clinical workforce? Without the clinical workforce, you cannot provide the services. So I am not suggesting not factoring that in, but it is also in considerations of the patient experience and how do we account for both. So patients are thinking about convenience. They're thinking about what type of environmental setting do I want to be walking into? Does it feel clean? Does it feel trustworthy? And most importantly, patients are going to be paying attention to, is my appointment on time? And can I maintain a cohesive relationship with the provider who is providing my care? For the clinician, they are thinking about all the things that you and I think about when we want a good place to work. Is it comfortable to be in? Do I have space to work quietly to think? Are the tools that I need readily at my disposal? Do I have space somewhere to take lunch and interact with colleagues? And are the logistics convenient, let alone all of the details about what it takes to actually provide the care and for the patients? And so we need to be able to meld both together. And sometimes there could be conflicts, but oftentimes there's more aligned than we might originally think.
Maybe take a specific example. I think it's the bane of the experience for many patients, which is the waiting room. Is the waiting room a legacy artifact of us needing to have patients there sufficiently to keep our clinicians busy? If you could design from scratch, would you get rid of it?
Of course, in an ideal world, as a patient, I wouldn't want a waiting room. I would be able to want to show up to a clinic to check in immediately and go be directed to the care that I need. Unfortunately, the operational realities of that, I don't think are going to allow us to fully deprecate the waiting room in many instances. And that is because we cannot control for the variability of a patient arrival to a physical space. All of the reasons that we know that patients are late to appointments, until we can control for that degree of variation, we won't be able to fully eliminate it. Not to mention the fact there are, depending, going back to our original question of identifying our target patient, if you are in pediatric care or working with teenagers, there are often going to be parents or caregivers driving and bringing the patient in who need a space to wait. Same for our Medicare population who might have a caregiver who is helping provide them transport. There is often a need beyond just the patient, but the reality is that any care practice, the heart of a sound economic model is being able to have as full to fully utilize providers to the extent possible, to utilize, to have to and to not have appointments be delayed. And so when you are thinking about keeping the supply of patients moving smoothly, unfortunately, the waiting room does become a necessary evil to maintain, and in many cases. Now, I do know, and there have been conversations that you raise in your articles and that we've had before, Adam, about where might technology play a role. I do think and have seen some practices experiment with location tracking. If a patient is using your app, can you track them to help determine if a provider's schedule is running on time or not? I think the reality is, though, I have a reasonable degree of skepticism that we're going to see high patient adoption of providing those permissions to be tracked on a regular basis. Absolutely worth exploring, but would be cautious with that investment and the degree of uptake that we expect patients to be open to.
That's really interesting. Maybe we'll have time to get back to patients' willingness to make it easier in their own experience, but giving up some of their privacy in terms of where they are. Before we get into more specifics about the clinic, in the list of priorities in designing, you didn't mention brand, the credibility of the clinic, just the physical space providing confidence. How do you think about our buildings have been part of the way a patient recognizes that we're there, we're stable, we're in the community? As we move to more hybrid models, do we need to think about that as a specific reason to have a physical space and some of the uses of it?
For me, that would be a lower priority. And with the caveat that it depends on the brand. And so naturally, if you are an outpatient clinic affiliated with a larger health system, then there is an expectation for that might be affiliated with that brand for being able to receive multiple services in a single location. You often see large campuses where you can go see a provider, but then also in the same location, go to a lab to get your blood drawn, go have imaging done. And so it is less about the brand of the particular organization, but more what it represents in terms of being able to receive multiple services in a seamless patient experience without having to schedule 3 other follow-on appointments, as an example. I have been impressed, both from the business side and as a patient and consumer of healthcare for myself and my family, at the brands that are being established for virtual-only providers, where they don't have the physical presence, but because of the modality, right? Mental health, subspecialties, anything where there is remote monitoring happening in the home, where they do not need the physical space brand. And so we are seeing further and further proof that is not necessarily a requirement.
Interesting. Again, I don't think we'll have time to get to it, and I don't have data, but part of my thesis is, again, depends on the population, depends on the service. As you said, mental health may be different than primary care, but part of my anecdotal experience is those virtual only brands have trouble with retention and trouble maintaining luxury kind of premium positioning. We sort of race to an expectation that it's omnipresent. And so I think there's an interesting conversation about a luxury clinic versus not, and what's the role of the physical space. As a reminder to the audience, please send in questions. We, Bearing on Health, like to keep these short so we can get an audience to come, but that means we only have about 25 minutes for a conversation, and we want to take your questions if we get there. Shifting a little to actually building the clinic, we've heard a lot in the newsletter, went back and forth on this concept of a modular clinic. Really mean operationally? Does it mean I can move the walls around? Does it mean that like the rooms are different? Does it mean I just have to have flex space that can go? How do you think about a modular clinic?
Sure. So, yes, let's, I want to separate what is possible from what is most likely feasible. So, yes, we can make clinics modular. We can have temporary walls, right? We all know that construction costs are very high. Actually, let me pause and step back. So let's ask ourselves, why are we even thinking about something being modular, and why does that matter? So we can think about making the physical space modular. The reality is building and running a physical clinic is very expensive. And to be doing any custom build, you often need to be in longer leases of 7 to 10 years. Maybe at 5 years, you can get some custom construction done. And so if you are making a long-term commitment to a space and spending a lot of money, you want to have the confidence of knowing that you are going to be able to keep that clinic at capacity. That is a luxury that some more established brands and providers have, but is much more of a challenge for younger businesses or healthcare organizations that are branching into new service lines where they don't yet have the proof of concept for the brand. So when we're talking about modular, you can make your own space modular. There's different construction build options that will give you more flexibility. There's flexibility in the furniture and assets you put into this space. Are you buying it?
Not just the space itself, but
Designing?
you fill it.
Are you leasing it? There's modular in terms of, do you need the lease yourself? Is there the equivalent of a WeWork, co-working spaces? You see this in mental health. There are other, just the same way that in a hair salon, someone can lease a space, lease a chair. There are providers where if they are solo practitioners in particular, then they could have the option to come in and out and have a shared space. So I think it's about providing flexibility and what stage of maturity an organization is to be able to make the upfront capital commitment to do the build out and have the confidence that they will be able to sustain that cost structure over a multi-year time horizon.
Yeah, it's a really compelling way to look at it. I've spent most of my career on the virtual first, and I'm coming later to the physical space. And I think it's a really interesting time. We're in between, right? It took a long time to get virtual care, telemedicine, whatever you want to call it, going, but it basically ran separately from in-person. I think we would all point to the pandemic as a moment of, okay, we went from a lot of in-person to virtual, but we didn't have to solve this hybrid model. So in this world where we're still evolving, what is the right mix of what happens in person, what should happen virtually? Again, that's different for every population, but even within that population, patients want different things. This modular concept is one of the ways to de-risk it, but if you were advising a established in-person health system provider who wants to go hybrid or virtual only, how do you help them de-risk this? Maybe it's a decade or more till the model really plays out in terms of hybrid care.
Sure. And I want to come back. I want to answer that and come back to a part of your prior question that I didn't fully address about hybrid models, virtual models not being able to retain patients. And I want to start with your prior question first and lead into this. Part of the problem with why patients haven't retained is that some of the businesses that are providing virtual care are focusing on areas that patients themselves see as more episodic, right? They are not, the patient is not perceiving and understanding a long-term value and long-term needs. So there is a large need for patient education of how to be able to think about their own health and care differently, right? It is no surprise to any of us that we are an instant gratification culture, but that for long-term health and sustainable results, it takes weeks, months, years of focused effort and behavior lifestyle change or testing different medications. So part of it is patient education. Part of it is companies making sure that if they are virtual only, that they are serving enough need that have a longitudinal perspective. So now coming back to your question of doing this in a hybrid model, how do you figure out? So if you have it in person, then you don't need necessarily to have the longitudinal relationship be over a long period of time if it is virtual only. The challenge that you have to think about is where are you going to start cannibalizing your own in-person business because you're not going to have enough volume. And can you grow is your growth engine for finding new patients to serve sufficient that you can then fill the capacity where you've already signed a multi-year lease and hired in-person clinicians? So that's one thing to keep in mind. Secondly is keeping in mind how you use the physician's time, right? Are you paying physicians to split their time, but they are spending most of it sitting on Zoom in a physical office that you were paying a very high overhead cost for? Operationally, not as efficient. The problem is the patient has an expectation for continuity of their provider relationship. So doing thoughtful supply demand planning to figure out how to balance the provider utilization between the physical and the virtual, it is a core part of what the business needs to figure out.
Yeah, I think that's really compelling. The almost at the core business model of in-person has been asset utilization is a fundamental financial metric. And not all, but a lot of the virtual care have thought about sort of membership and subscription and monthly active users. And even those business models think differently. Maybe let me give you an example that I've thought a lot about in terms of this modular, but also evolving. I have a thesis that one of the moments to build a relationship with a patient, and I'm thinking in primary care, is the more in-depth sit down with the patient once they've completed a set of diagnostics to talk about where they are. Grant me for a second that right now, most patients want that in person. You could imagine a world, though, that over time, as we become more comfortable, as there's different technologies to present things, that a percent of patients that, let's say it was 80 wanted in person and 20 were comfortable, it becomes 20 need to go in person. What do I do with that space if that plays out over 10 years at the whole time of the lease? Because I built a room, shows these diagnostics, sits with them, is comforting about this sort of upfront example. How do we think about building a space that works now, but may change as that utilization is different in 5 years?
Yes, it is a really tough challenge. So first of all, any business that's looking to pivot, but already has the physical commitments, is going to have to ask itself, first of all, to the point that I raised before, is there a growth engine that can be turned on to help attract more patients to the space? And that could be better advertising or having additional contracts for existing services. This may be a strategic decision of having to think about expanding other service lines or offerings. So I know you were giving the example of primary care, but I've spoken with many primary care physicians and practices who ask themselves, okay, if we are moving more to virtual, what are other services that our patients are often looking for where it would make sense to have another physician co-locate to help take that space? So that is an option that some are forced to contend with. But it is worth noting that presents some challenges unto itself if you think about the check-in area and the design, because there are regulatory requirements that dictate how space can and cannot be shared by different provider groups and entities to help protect for patient confidentiality. So not insurmountable, but things that have to be factored in before a partnership is forged.
Interesting. And you've worked with maybe more hybrid care models than really anyone. What do you see people miss most often, or what's most often overlooked when they come into this journey?
Ooh. Where I see a lot of hybrid clinics. So let's use both scenarios. So the scenario of physical clinics that are adding virtual care that have existed for a while, they over time have to invest in a lot more physical infrastructure to provide an optimal telemedicine experience for the patients and for the providers, whether it's stand desks, larger screens, better video technologies, internet reliability, the queuing systems for being able to maintain those and coordinate it with what is and isn't happening. It is very much the case. I'd welcome if anyone has seen data on this, but that is aggregated across multiple providers. But in the virtual world, patients expect punctuality. There is a tolerance for appointments running a little bit late in a physical environment because that's what patients are used to. But I see it in multiple organizations where patients, if a provider is just a minute or two late, will not take the video call. So it's a very different margin of error that is understood. And so that's something else that all of the schedule planning and coordination that works in a physical environment and that works in a telemedicine only environment gets even more complicated when needing to harmonize the two together because you are sharing providers across both.
Again, really compelling. If anyone does have data, if we find it, we'll absolutely share it. That issue of different expectations on the same service, meaning it's an appointment, but because I'm physically there, I have a different expectation of weight or tolerance, maybe is a better word than if it's virtual, and blending those. I think one of the things we heard from our readers was virtual care can feel fragmented and has a sort of like transactional expectation of it. Have you seen best practices, or what would you share to folks, whether they're trying to move from virtual to hybrid physical or otherwise, to build and maintain those relationships so that they don't feel so transactional? So to your point, I know my physician, and if he or she is 2 or 3 minutes late, I'm willing to grant them that grace because I know who they are and I have a relationship, and I'm not just, this has got to get done right now feeling.
Yeah. And to me, the transactional relationship has less to do with the modality and much more to do with the staffing models. Is this a clinical business? Is this a clinical practice where we are establishing a primary provider or care extender, many different types of care, not only just delivered by physicians, where the relationship is maintained across appointments? Or is it more randomized and based on a pool of clinicians with random assignment? I think the reality is patients for emergent care, for things where you either need it urgently or you're just getting it single episodic, certain tests, lab images, etc., do feel things that are done as one-offs, going for an EMG, etc. Patients are often comfortable with working with different individuals over time. But when you are trying to solve a problem that needs to follow a trend over time, that needs to look at whole person care, the patient expects a consistent relationship, whether that is in person or virtual. And so I think the problem that some telemedicine only companies are facing is that they're using the pooling approach too readily in order to have economic saving, but the care that they're trying to provide requires, or at least the patient expects, a longitudinal relationship.
I think if we go back to the business models, and I hate to say it this way, but to some extent, the employed clinician is thought of as an asset, and you have an asset utilization issue in the same way you have with the physical space. I think you're right that some of the virtual care companies have tried to get around that as the core way to think about it by having a pool of clinicians that they can assign on demand. And so they're not as struck by, I have to fill these people. But on the other hand, it becomes hard to establish an ongoing relationship.
And it comes back to the point that you raised before about why are they not retaining patients?
Yeah.
Patients are not retaining because they don't feel a connection. And the reality is, even in the best tech-enabled care delivery business, anything delivering care still requires a human for so much of it. Just the regulatory environment has not allowed us to get, plus the technology, plus the human change management barriers all together have not gotten us to a place where the care can be absent. And so that care still has to have a human in so many parts of it. And humans want relationships. In our healthcare, so much is there's more and more medical evidence about how trust in a relationship, as well as and the mental health benefits that provides to the patient, impacts all the other physical ailments that our very hardworking clinical teams and the administrative teams that support them are working to provide.
Debbie, I wish we had more time. We've got our own questions. We didn't even get to any audience questions, but this was really compelling. And I think it's a good place to leave that virtual is solving real challenges on the in-person side about access, about what you need. But at the end of the day, we still want trust and relationships in most of the care, and we've got to balance those. And they built different commercial models that do it. I wish I had a chance to ask you what the clinic looks like in 10 years and 100 years. We'll have to have you back on for another conversation. Anything you wanted to add before we break here?
No, just really excited to be here. Thank you so much. Really appreciate you fostering the conversation so that we can collectively, as an industry, work to make these improvements to achieve the ultimate goals that we're all working towards, improving access and improving quality and patient outcomes. So thanks for raising a lot of the tough questions.
Perfect. Thank you, Debbie. Thank you to everyone who joined us. And we look forward to the next conversation. Have a great rest of the day.
Thanks, Adam. Thanks, everyone.